Okay, so so this is, this is what I do. I really love doing epi study design and analysis. So I could talk for days about this, but I'll just give you a sort of brief introduction. So first we're going to talk about correlation and causation. So this is something that is not specific to epidemiology, and most of what I'm talking about is actually not specific to epidemiology. There are a bunch of different fields that do observational research, and we all share some common strengths, limitations, and principles. We have a different vocabulary, so that's where things get a little tricky, and some different sort of takes on things. But in general, I'm an epidemiologist, that's my background, and that's where I'm most comfortable talking about these things. But if you've got questions about, from an econ perspective or sociology perspective, there's a lot of the same sorts of techniques and ideas, just slightly different vocabulary, slightly different frame on how we do things. And I have tried to get conversant enough that we can, talk about, where things might be similar and where there might be some differences. So also stop me if you've got any questions or comments as I go along. So we're going to talk about correlation and causation, developing a testable hypothesis. This is something that we've covered a couple of times in a couple of different ways already, but it's really important. So I'll cover it just briefly. Designing an epidemiologic study, and then some resources for where you can go for additional help and feedback. So to start with, one of the things that you hear a lot sort of in the lay press is correlation doesn't equal causation. Totally agree. So why not? If you see, the rooster crowing, sun comes up. Can you say that the rooster is causing the sun to come up? No, right? Why not?
Independent processes.
Or independent processes, right? So it's not like one thing is causing the other. Though you might argue that sort of the rooster is responding to the sort of circadian rhythm, right? But right, it's not like, one thing happens and then something else happens, and therefore those two things are causing each other. One causes the other. And in general, we think, the reason is biases, right? So the bias in the case of the rooster and the sun is that the rooster is responding to something that we're not seeing, right? So the rooster is responding to a circadian rhythm that is related to the sun coming up, but it's not sort of that sort of directionality in terms of cause. As epidemiologists, we describe biases. Economists will talk about other types of biases. So what we call confounding as epidemiologists, economists tend to call endogeneity, similar type of idea. Measurement error, selection bias, and others. So some people's training, they learn about very specific types of biases, and they call them very specific things. My training was very much like, okay, you have these sort of big buckets of bias, and the other sort of different scenarios, but thinking about the big buckets is more useful than thinking about the different names. I'm not sure one is right or one is wrong, but these are sort of the ones that I think about. So measurement error is sort of self-explanatory, right? You're not measuring what you think you're measuring, or you're measuring it poorly. I'll talk a little bit about confounding and selection bias. So the basic idea with confounding is that people who are exposed are different than people who are not exposed in ways that are not necessarily directly related to, or not an outcome of that exposure. Another way to think about this is that the risk of your outcome is different in the exposed and the unexposed group in ways that are independent of the exposure. So if we are interested in the relationship between obesity and myocardial infarction, right? So that's something we want to know. So if we look at, obesity status and MI, what we're going to see is that obese people tend to be older than non-obese people. People tend to gain weight as they age. And we know that age is a very strong risk factor for myocardial infarction. So if we just look at the group with obesity and the group without obesity, we're going to see that the rate of MI is higher in the group with obesity, but part of that is going to be explained by age, right? And so what I've drawn here is just sort of a simple diagram. It actually is kind of cool. There's a whole math behind these types of diagrams. They get very complicated. They're called directed acyclic graphs. They get used in computer science and other places, and then more in the last, say, 20 years, they've been pulled into epidemiology. And if you're interested, they could be really helpful about thinking about making you sit down and say, how do I think the world is working, right? So I know that obesity is not causing age. That's just not logically possible. But I know that as people age, they tend to gain weight. And I know that as they age, the risk of myocardial infarction goes up. So some proportion of the association between obesity and myocardial infarction is due to age. So age is a confounder in this situation. So our solution is to control for age. There's a bunch of different ways to do this, and this is sort of more on the biostat side of things. But we can measure age, we can adjust for it, we can take that into account. If we think about, on the other hand, another example, so if we think about, we want to know about fruit intake and obesity, right? So does fruit intake reduce your risk of obesity? There's some suggestion that maybe it does. The problem is that people who have a propensity to be healthy, right? So they're health conscious, are less likely to be obese, and they are more likely to eat a lot of fruits and vegetables. Right? So this is something that, this diagram is sort of writing down my assumptions about the way the world works. And so I think that if I just looked at this association, some part of the association between fruit intake and obesity is due to being healthy. Problem is, how do we measure healthy, right? So for age, we have a pretty good measurement of age. People generally can tell you how old they are, or we can go to vital records. When we think about propensity to be healthy, so this is a much more nebulous concept, right? A much harder thing to measure. There are ways to do it. You can get proxy measures. So for example, some of the stuff that we do will look at, did you get your mammogram? So it's unlikely to be directly related to these things, but someone who regularly gets a mammogram and is like following all of the rules and is adhering to all of their medications is more likely to be sort of healthy as we think about it. If you're in sort of a more social science field, you might do some sort of latent variable sort of approach where you've got the questionnaire and you're sort of capturing that information and then you're capturing that concept of health. So not everything that sort of looks like this diagram is necessarily going to be a confounder. So this is one of the things where you don't want to just sort of go through and just think everything is a confounder. Because if we want to know about the relationship between obesity and myocardial infarction, right, one of the ways that obesity causes myocardial infarction is that it increases your risk of diabetes, and then diabetes increases your risk of MI. So in this case, diabetes is not a confounder here, right? Diabetes is on the causal pathway. So, if you have taken an epidemiology class, they will generally tell you, do not use the automated variable selection. Because if you use some sort of automated variable selection and you're doing some sort of modeling exercise in a statistical software package, it's going to pull out diabetes. But if you put that in your model, it's going to be adjusting away part of your association between obesity and MI. Does that make sense? So confounding is one of the major biases we think about. Selection bias is another one. And this one gets a little trickier and is a little harder to explain. But I worked on this example for a while and I kind of like this one. So hopefully you guys will like it too. You can please give me feedback. So selection bias occurs when the exposure, right? So whether or not you have the exposure of interest is related to whether or not you wind up in that study. And so one of the ways that this happens is differential loss to follow-up. So here's my example. So if we wanted to know rural residents and cardiovascular disease among people with cancer, right? So there's reasons to think that maybe people with cancer who live in rural areas have a higher risk of cardiovascular disease because they have less access to care or other sorts of exposures like that. So if we select our study population, we go to UAB and we say, okay, everybody who got their initial cancer treatment at UAB is our study population. And we want to know, how does that affect, how does being rural versus urban affect the risk of cardiovascular disease? So what happens is that if we were using the UAB EMR, what we would see was people who got their cardiovascular disease treated at UAB, right? But if you think about, if you have cancer, right, you almost always, to get your initial cancer treatment, to get your first surgery or radiation, you have some time, right? You're gonna sort of go to the best place you can reach plausibly, and that your insurance pays and all of those other complicated things, but it's not like you gotta get there in the next hour. If you're having a heart attack or a stroke, even if UAB would be the better hospital, but you're in Jasper and you have a heart attack, you probably wanna at least start your care in Jasper, right? So what winds up happening is that whether or not, so what we wanna know, right, is this rural CVD relationship. But the people we can see are only the people who got treated at UAB, if we've got the UAB EMR as our data source. So what you might get a biased selection in that, because who you can see, whether or not they got cardiovascular treatment or had a cardiovascular event, is going to be related to whether or not they're rural. Make sense? Okay. So, like I said, I know that we've talked about this in a couple of different forums. So Dr. Charrington talked about this a couple weeks ago, and then last week, Kay Smith was talking about this as well when you're thinking about doing a literature search. So for my postdoc, I was interested in whether diet affects heart failure. But this is not really an answerable question, right? So, because we need to know like what aspects of diet, specific foods and nutrients, am I talking about diet patterns, deficiencies, overload, what exactly is it about diet? And affects how, right? So am I thinking it's gonna prevent it, slow progression, prevent mortality, reduce symptoms, right? There's all these different ways that there could be an influence of diet in heart failure. Then we also wanna think about who. So older people, women, people with diabetes, mice, at the time, so now there's a good bit of literature on this topic in terms of incidence, diet and incidence of heart failure, which is what I wound up looking at. At the time when I was doing this, most of the studies were done in Great Danes, because I guess there's some sort of nutritional problem with Great Danes. But thinking about what is your target population? So when you think about what makes for a good research question, there are sort of these, for thinking about the idea, there's the finer criteria, and then for the framing, there's a PICOT approach. And there's different ways of doing this, but these are two that I think are useful. So finer is feasible, interesting, novel, ethical, and relevant. Clearly, none of these are absolutes, right? So there are studies that are feasible for you as a trainee studies that are feasible for me as a faculty member that wouldn't be necessarily feasible for a trainee. There are studies that, so say George Howard in the School of Public Health, who does these enormous, massive, like very complicated studies that I don't think I could ever pull off. So I think that there's, that's not an absolute. Interesting, again, you don't want to do a study that you think is boring, but you have to convince people that your study is interesting. Novel, again, you don't want to do the same thing over and over again, but nothing, there's always something out there in the literature. We're never thinking about something that no one has ever thought of before. Maybe it happens occasionally, but that's very, very rare. Ethical, and again, this is a sort of a course, but then you look at some of the studies that have been done, and you're like, wow, how'd you get that through the IRB? So there was one that was done that was super interesting, where they put the people who had heart attacks, and they put them on exercise bikes with, wired up to electrocardiogram while they were breathing diesel exhaust through a mask. And I was like, whoa, how did you get that through the IRB? But it's really, it's scientifically super interesting, because they show that it does actually transiently increase ischemia, that, that is, the diesel exhaust has a real mechanistic effect. But again, whew, I would be very nervous about doing that. Relevant, so this is, you know, is this historical? Maybe that's useful, but maybe it's not. So I was doing the study and I had this whole complicated model that I had come up with, and I was like, oh, this is super cool. We can look at, you know, how did hospitals change in response to guideline changes? And I was talking to one of my clinician partners, and they're like, yeah, the guidelines were like, that was like 5 years ago. No one cares what the old guidelines were, right? So like, we want to look at what's happening now. PICO, so again, this is very similar to what Kay talked about last week, but I've added one, right? So we've got our patient population, our intervention, comparison, outcome. The last one I've added is time frame. So as an epidemiologist, I think time frame is very important. So here's my silly example. So is rabies infection associated with a higher risk of death? Right? Yeah, of course it is. But if we think about, okay, so say 5 of us in this room are infected with rabies, and the rest of us are not, 100 years from now, what proportion of us will be dead in the rabies group? Everybody. What proportion of us in the non-rabies group will be dead? Everybody, right? So if you think about, you know, timeline, like, yes, if you get infected with rabies, it's really bad for you right now, and for the next couple of months. But you know, if you follow people out long enough, you've got 100% mortality in your exposed group and 100% in your unexposed group. So now your risk ratio is 1. Right? So specifying what the timing is very important. A less sort of silly example is thinking about, okay, if you were going to do a study looking at, say, disparities in outcomes for people with HIV, right? You might think that sort of what's happening now might be very different than what was happening in the 1980s, right? When the epidemic was new. And, you know, so thinking about, you know, those relationships might have changed because the treatment of HIV has changed a lot, or knowledge of it has changed a lot. The social services around HIV have changed a lot over the last, you know, 30, 40 years, right? So, or 30-ish years. So thinking about what is your time frame is very important. So this is one that I've added, and that is added in some of those PICO. So some of them are just the PICO and some of them are PICOT. So here's my slightly better question. So thinking about intake of fatty fish associated with hospitalization for a death from heart failure among women. To get a little more specific, when we're talking about fatty fish, this is Sweden, so we're talking about salmon, herring, and mackerel. So people don't really eat herring and mackerel in the US, they do eat salmon, or at least not in any great quantities. We had about 9 years of follow-up. We had, you know, a particular subgroup of women living in 2 counties in central Sweden. We're just looking at their first heart failure events. We're looking at incident heart failure. And this is what we found, just to show you the results. We see that the more fatty fish you eat, the better, up until maybe about greater than 3 times per week. This is an interesting population to study, fatty fish intake. In the US, there have been a bunch of studies in the US. In the US, fatty fish intake is associated with socioeconomic status. So more well-off people tend to eat more fish, and specifically more salmon and tuna in the US. In Sweden, almost everyone is actually eating fatty fish once per week. So that is by far the biggest group. And the people who are eating fatty fish more than that are largely eating pickled herring and drinking heavily in bars. So we try to adjust for some of that, but you know, I think that's probably what's going on here, is that people are, it's not necessarily like a healthy sort of thing to do, and you know, we're trying to adjust for alcohol intake, but it's, people lie about their alcohol intake. Questions? So yesterday, the day before, I was reading this article in the Washington Post. There was an interview with a scientist, an animal behavior scientist, who was talking about, do dogs love, right? So do dogs actually love people? And it was really interesting because he was talking about how when you do a research study, you answer a very small question, right? Because you can't really answer the big questions. So you cannot do a research study really that tells you, do dogs love people? But what you can do is you can do a bunch of small studies that look at, how do dogs respond? Does their, will they prioritize, their person versus food? They'll do all of these different things. And then sort of from that, you build up more of an idea of sort of the way the world works, and a bigger question like, do dogs love people? So his conclusion was yes, but he was talking about how it was interesting because the interviewer, I think, had probably asked him a question about like, okay, so this study you did that was about like gregariousness or some trait that he had done in dogs. He was like, is that how you're judging this? And he's saying, no, it's really the sort of gestalt from all of the studies that we've done, because the study that I just recently published answered a very small question. So I thought that was kind of interesting. Also because I have dogs, so I particularly thought that was interesting. Okay, so when we think about designing an epi study, we'll sort of sit down, we'll work through the PICOT criteria. We're already sort of saying that we think that it's feasible, interesting, novel, ethical, and relevant, and sort of think about what are specifying as much as we can what these things are, and then thinking about study design. So does anybody want to have a study idea and want to sort of work through this with me? Sort of like, this is what I would do as a consult for like the biostats epi research design. Anyone want to volunteer? No takers? Okay.
I'll volunteer.
Okay, awesome. So what's the outcome you're interested in?
So I'm interested in all-cause mortality.
Okay. So that is a very nice, solid outcome that we can generally measure pretty well. Okay. What's your exposure intervention?
My exposure is going to be missed primary HIV care clinic visits.
Okay, so you want to know, does missing your primary care HIV visit increase your risk of mortality? Mm-hmm. Okay. And so this is comparing who?
So want to look at, are there differences based upon age, race, ethnicity? So look at, are there differences among, so it's been established that there's a correlation mm-hmm. between missing visits and mortality. I want to know, are the effects the same across different groups, or okay. do they vary or differ across different groups?
So that is a question, that's sort of an effect modification question, right? Or so you want to say, so what you're doing is you're saying, okay, people who are adherent to their visit schedule versus people who are not, right? How are you defining missing a visit? I know this, since we're working together, I know this is not actually straightforward. So how do you define missing a visit?
So we're using administrative records from the clinics, using the scheduling and billing systems, mm-hmm. And whatever is documented there is someone having a no-show visit, not calling ahead to cancel and not attending their visit.
Okay, so this is no-shows, right? So if somebody keeps canceling, they don't wind up in that missing visits, right?
Correct.
Okay, so, and if you show up when the system thinks you're supposed to show up and you're not, then you're adherent. Okay. And then you want to know, okay, so you want to know about whether that association varies across age and other characteristics. Okay, so that's a third variable, right? So that PICOT doesn't necessarily capture that effect modification question, but it's saying like, okay, maybe visit adherence is a bigger deal in older than younger people, or vice versa, or maybe people who are socially vulnerable for one reason or another, attending that clinic visit might be a bigger deal than for people who are less so.
Okay. One important point on this idea of heterogeneity by treatment effect, which is essentially what that is that if you write a grant to NIH, they want you to generally be able to look at sex as a biological variable. see whether it varies, your treatment effect, the effect of your intervention or exposure varies by sex is really important in writing grants today.
Yes. So recently, NIH decided that it was no longer okay to just do studies in men or just do studies in women. I think that actually the bigger deal was that people had been historically doing studies just in male mice or male rats. For what we do, yes, there is some gender bias, but I think it's much less than in basic science, where it's just easier to do, one group than another. So yes, that is absolutely true. If you're going to write a grant and you're going to have only men or only women in your study, you need to have a really good reason why. Of course, there are really good reasons why, right? So if you're studying breast cancer, it makes sense to study women. If you're studying prostate cancer, it makes sense to study men. So yes.
I was just curious if you could explain effective modification.
Right. So wish I had a piece of paper or a whiteboard. So effect modification is the idea that your exposure might operate differently in one group than another. So that you have this, so you have your exposure, you have your outcome, right? And that there might be some factor that changes how that exposure and that outcome are related. And again, this is a silly extreme example that gets used in sort of a lot of the intro epi classes. But if you think about it, right, so phenylalanine is an amino acid. It's in lots of different foods. It's particularly in artificial sweeteners, high concentration in artificial sweeteners. So think about, okay, so does phenylalanine increase the risk of brain damage? Probably for most people, no, right? But if you have phenylketonuria, which is a genetic disease, which means that you can't metabolize this, then yes, it actually intake of phenylalanine increases your risk of damage to brain and other systems. So having that genetic change means that the way that phenylalanine works on brain function is very different in people who have, who can metabolize phenylalanine and people who cannot metabolize phenylalanine. So that's a very extreme example of effect modification. So there's no association in one group and a very strong association in another. To Muggs's point, for his example, it's probably going to be a little more subtle, right? So we know that from prior studies, we know that missing visits is associated with bad outcomes. We might hypothesize, I don't know, what was your hypothesis about who was going to have the strongest association?
I think it'll be younger individuals, and if we have some surrogate for SDS, be it private insurance, so it would be always two of the factors where we think there's going to be a.
Okay. So for the example we're talking about, the idea would be that the association of missing visits and mortality is going to be stronger among younger people than among older people. And it's going to be stronger among people who have fewer resources. So, measured by, again, these proxy measures like, did you have, like private insurance through your employer versus a public insurance or no insurance option.
So the effect modifier in that situation is your SES status, for example, or your age.
Correct. So your age or your SES would be the effect modifier, missing visits would be your exposure, and mortality would be your outcome.
In other times when we see this, it becomes tricky because sometimes, and look to you all to help us with the epi, even like race by sex differences. So the idea, if we just look at men and women, or just look at African American and white, we don't pick up on the fact there might be differences if you cross those two. African American men, women, white men, women. So sometimes I've done those with an interaction term, which sometimes I think can be, for a clinician, more challenging to interpret. Other times, that's like, we're just going to stratify up front. We're not going to look at these two things separately. We're going to stratify and look separately at African American men, women, white men, and women to kind of look at some of the potential different effect modification in this very specific, cross event.
And from my perspective, those are mathematically almost exactly the same thing, including the interact. Yeah.
Can I ask a question about that? So recently had the experience with the junior faculty member who submitted a paper who did a stratified analysis, and I've heard this, seen this feedback before, is that you have to test the interaction first before you do the stratified analysis, and then that was like a deal breaker for them. So, are there your feelings on that? Is there, can you just say, because of literature or whatever, we have reason to believe that these ought to be looked at in two different groups, justified? Is there some math reason you have to do the practice?
No, there is.
That a lot.
So, right. So the question is, if you think that there may be, that maybe this is, you know, say your missed visits and mortality is going to be different in younger and older individuals, the question is, do you have to test for whether that's statistically significant before you take a look at it? My opinion is no. My opinion is that, you know, if you have a strong a priori hypothesis, you can go ahead and do the stratified analysis. The tricky thing there, though, is you can't, I would push back at you if you said these things are different without testing for whether they're statistically different. So that's.
So you can display the differences, but you can't say that they're actually different.
Unless you test, right? I mean, or you can say there's a suggestion of difference that is not statistically significant, stronger in one group than another, but no statistically significant difference. What is really problematic is if you say, okay, so the main association between your exposure and your outcome is statistically significant in one group, but not statistically significant in the other, and then you say, oh, these are different. That's not right, because what happens is that if you have a smaller subgroup, right? So if you're, in your case, if you're thinking about mortality, you're not going to have very high mortality in the younger group, right? Because they're younger, and age is a major risk factor for mortality. So, you know, if you're going to tell me that, you know, if it's not statistically significant in the younger group, but it is in the older group, that doesn't necessarily mean that there's effect modification there. Mm-hmm.
I'm wondering about when you look at administrative databases and you're looking backwards, there's these time points, if you think about HIV, where primary care might mean a lot more after a certain time period. So you may not get much of a difference in mortality in primary care in 1991, and you may get more in 2001, and you may get a whole lot more in 2011. So how do you control for changes in clinical practice?
So you're sort of, can we put that, can I table that till we get to the time frame question? Thank you. Other questions before we go on? So who's your patient population? Or who's your study population?
So the population I would love is like the universe of all people living with HIV in the US, right, to be represented. I think the patient population I can study are people living with HIV who have access care at one of 8 clinical sites at, you know, these academically affiliated clinics that are part of this national network. Okay. So what you really want to talk about is all people in the US living with HIV. Right. Who you're actually going to study are people in the US living with HIV who receive care at academic medical centers who are part of this network. Okay. So it's important to remember like what you want to do and what you can do. And, you know, I think that what you can do is often can tell you about what you want to do, but you need to be careful to think about, okay, maybe it's different if you're not being seen at UAB, but you're being seen, you know, at a smaller clinic at somewhere else. Okay, so now we can get to time frame. So what are you thinking about? So both how long are you following people and what sort of era are you thinking about? Whoops. But I think I would say this is the place I would ask for help. So when we've done this in the past, you know, this is a study published 10 years ago. So looked at a time frame from 2004 to 2006, and clearly treatment has changed. And when we studied it in the past has been, let's look at persons who are newly diagnosed and new to care, so have more homogeneous sample in terms of being, you know, at the same point of entering care, and look at the first year after entering care. Okay. And said, you know, you have to survive that first year. So if you die in the first year, you're, you know, excluded. But and then just as a count measure, in that first 12 months, how many visits did you miss? And then after 12 months, start a survival clock. So this is how we've done this in the past. And some of the questions that have come up is, treatment has changed, treatment is different. While it might have mattered in 2004 to 2006, it doesn't matter in a more contemporary period. So I think in terms of, we want to start, study a more contemporary period, whether to focus exclusively on those new to care or to think more broadly about also those who are in care, and whether to think about doing it for a fixed time period and monitoring outcome versus some kind of a time updated, I think are all things that would be very open in terms of thinking about how to design a good study. But the questions that came up were, it's mattered 10 years ago, does it matter now? And then also this idea of, are there subgroup or is there effect modification in certain groups that are more impacted than others?
Okay. So why might it be that it would matter 10 years ago but not now?
I think some of the argument is the therapies are so much better that, and so much more forgiving that, in the past, there's been advances in treatment such that the therapeutic advances render having missed a visit or not. And I think even going to the issue of causality, this has always been this idea that the missed visit is not causally responsible, but an indicator to us clinically that whether it's something in someone's life, those kind of things. But even then, with that kind of push, feedback, folks will still say, it doesn't matter. It doesn't matter in 2019 because treatment's so good that even if folks are missing now and again, it really doesn't make a difference.
Okay. And then there are a couple of other aspects of time that you mentioned there. So one was, how long have you been in HIV care? So you're saying, should you just say, start the clock when you get diagnosed? Should you take more of sort of a general census of your clinic population? And those groups, why might those groups be different? Would you think, are these groups different?
I think they're really different. Right, so folks newly diagnosed, newly entering care, if you look at a sample of folks, who are in care, that includes those who've been in care for 20 years, 10 years, there's some selection bias in who that group is, relative to the new group, and some differences, between those two groups.
Right. And then the other thing you mentioned was about, that affects the time dimension is rates, right? So a rate is the number of events, so the number of deaths over the amount of time, person time of follow-up. So how much time has elapsed. So what I showed you before was a risk, right? A risk is the proportion in one group, right? And then we divide it by the proportion in the other. So rates are less prone to that issue with, everybody dying eventually, right? So, if you were looking at our rabies example again, the rate of mortality would still be higher among those with rabies than those without. It's the risk that sort of has that funny time thing going on. So you could follow people out essentially as long as you wanted, without worrying about that sort of everybody going to 100% mortality. Does that make sense to people?
So is it fair to say that it's generally always better to have a longer period of follow-up, but what you're limited by are losses to follow-up and by practicality? It's often your resources. And the other concern, of course, is time varying covariates. If your exposure variables and covariates that are important change over time, that can confound the outcome. But better to have more time, if possible, depending, of course, on what the question is.
Right. So I think it really depends. For a question like that, so missed visits and mortality, yes, I would say as much time as you can capture. If it's a question about, say wound infection post-surgery, right? Then more time is not necessarily better, right? That there's some time at which, the infection is no longer likely to be related to that surgery. Yeah.
And going back to your comment about differential follow-up, and building on Ken's comment, part of why in the original study we chose to do 12 months of observation and start the survival clock was, we know from other studies, people at missed visits were more likely to fall out of care, and it's not at random. There are certain criteria that will select for those individuals, but by measuring all-cause mortality through administrative data, which is imperfect, but at least then, just because you fall out of care doesn't mean we cannot ascertain your vital status. So the idea was, by measuring 12 months and starting the survival clock, if there is differential loss to follow up longitudinally, it doesn't matter because we're still able to ascertain that outcome, even though we're not measuring you within the cohort after those 12 months. That was the rationale, at least for the original study.
Right. So if you're looking, right, so for mortality, you can follow people up more easily and you're less likely to lose them than for a lot of other outcomes that require participant like buy-in, right? So if you were looking at viral load, right, that would be much more problematic because if you fall out of care, you don't get the viral load measures. And that's going to be differential in a way. Whereas mortality, if you go to the, so you can go to the CDC, you can do what's called National Death Index search. That captures essentially everybody in the US.
Yeah, and the retention viral load quandaries plagued us forever.
Yes.
We can't, it's like people differentially fall out, so you don't measure them, so you measure them, so yes.
Yeah. So, okay, so those are the PICOT criteria. So then thinking about what are your confounders? So thinking about what would be the important confounders in the relationship between visit adherence or missed visits and mortality. So these are going to be things that are strongly associated with both your outcome, so the mortality and your exposure, so missing a visit. So what do you think? What would be the confounders that you worry about?
Can I ask for help? Can I?
Residents like travel to clinic.
So how far away you live, and then transportation barriers to clinic?
Medication adherence.
Medication adherence?
I have a question about confounding, and this just may be different fields, but is confounding in any way related to like mediation analysis? I mean, I know they're not the same.
Right. So mediation is sort of looking at what is explaining. So if you've got your exposure, which in this case is, did you miss a visit, and your outcome, all-cause mortality, mediation would be if you think that that's a causal effect. What are the downstream consequences of missing that visit that causes someone to have a higher risk of mortality? And so the mediation analysis is looking at things that are on that causal pathway. A confounder, on the other hand, is something that is a cause of your exposure and a cause of your outcome. So it precedes the confounder precedes your exposure, or is a proxy of something that precedes your exposure, whereas a mediator is something that follows on from your exposure.
Do you like the word cause there, or say it's associated with the exposure?
For confounding? Associated is too vague, right? Because a mediator is going to be associated with your exposure and your outcome. It has to precede your exposure.
So for example, viral load would be a mediator.
Viral load could be a mediator, right? So if you say that, missing a visit means you're less likely to have viral suppression, that your viral load is higher because you're not getting your medications optimized, and that's increasing your risk of mortality, that you could look at as a mediation analysis because you're thinking that missing a visit causes you to have a higher viral load, which then causes your mortality to increase.
And I think similarly, adherence, I think I would consider as being on the causal pathway and not a confounder. By missing visits, you don't have access to your medicines, you don't adhere to your medicines. So I think adherence is a good example, but I would actually think he's on the causal pathway and not necessarily meant to be treated as a confounder.
There was one other interesting comment made about distance or distance from the clinic.
Mm-hmm.
And so that's a really interesting one because that's seldom associated with the outcome. And in fact, it's often used as what's termed an instrumental variable. So that's a very classic example, something associated with the exposure, but generally how far you live away isn't kind of associated with whether you live or die. I mean, that's
Maybe I would actually argue that might.
It's a classic instrumental variable.
It is, but the big assumption is that living far away doesn't increase your risk of mortality for the instrumental variable to work, which is not necessarily.
Depends on the condition.
Yeah, it depends on the condition. Yeah. So, and then, thinking about, is medication adherence a mediator? Is it a confounder, right? So that's where these, the diagrams that I was showing you really can help, because I would think that there could be an argument made either way, that sort of medication adherence is like sort of a measure of being unhealthy, and that's also associated with missing your visits, or like having some sort of barriers in your life that means that you can't take care of your health, and that would be associated with both things. Or you could say that you could argue that in which case you would want to adjust for it as a confounder. Or you could argue that missing your visits causes you to be less adherent to your medications, and that in that case it's a mediator. So really sort of drawing this out and drawing out your best guess can be really helpful about thinking about, do you treat this as a confounder or a mediator?
And the key thing right there is that that's all theoretical.
Yes.
Math
Yeah,
is no different. I mean, so this is all really based upon theoretical and the literature and making that distinction.
And that's why I sort of disagreed with Ken when I was saying, is it associated? Because yes, it's going to be associated no matter whether your medication adherence precedes missing visits or sort of follows missing visits. If you have measurements over time, then you can get a little bit more granular, but if you're just sort of looking at a cross-section, you don't necessarily know which direction that is. So.
I think comorbidity burden, things like diabetes, hypertension, other things that potentially could be associated both with missing or not missing, and I think that certainly would be things to think about as confounders.
Mm-hmm. Okay, so comorbidity burden, some other measurements, and you probably want to also think about all of the things that you're thinking about stratifying on. You probably also want to consider as confounders as well. So then we think about study design. So the question is this a who, how many question? Is this a why question? How frequent is your outcome? Can exposure be measured after your outcome? So does the timing of when you measure something matter? Does prevalence tell you about incidence, right? So prevalence is a snapshot, how many people have a particular condition at a particular time. For mortality, prevalence doesn't make any sense, right? Because like among a study population, the prevalence of death is 0 at a particular time, right? Because people don't generally join your study after they've died. But if you think about, okay, what's the prevalence of breast cancer in a population, or what's the prevalence of having a cold in the population? Does that tell you about how frequently, which is that condition develops, which is the incidence question? How much time and money do you have, for a very practical question? And what has been done before? So the sort of most basic thing that we do as epidemiologists is surveillance. And this is not something that most academic epidemiologists spend a lot of their time on. This is really something that is mostly done in health departments or sort of as a hospital epidemiologist. We do some of it, and we work with people who do this kind of work. But this is really answering a question of how many, right? So systematic approach to determine how many people have a disease, so that's the prevalence, or how many people develop the disease. So as an example, there's this paper that came out a number of years ago. It was looking at Zika, so then this sort of came back in the news. It was looking at the Zika on Yap Island, which is a very small island in Micronesia, so they sort of have a very contained population. We're able to do a really rigorous evaluation of Zika antibody prevalence. So that's looking at how many people have evidence of having been infected at any given time, and then also the incidence. So for the prevalence surveillance, they sampled 200 of the 1,276 households. So again, this is a very small population, so you can get a handle on exactly who you're measuring and how many people are in your study population, or in your target population. They drew blood samples, and then they interviewed people about whether they had had symptoms similar to what we would think was Zika. What they found was that about 3/4 of this population had evidence of having been infected based on their antibodies. Of those who had antibodies, 38% reported symptoms, and of those who did not have antibodies, 19% reported having symptoms. So what does this tell you? What do you think about this? Do you think that everybody who gets infected gets sick? No, right? So there's a lot of subclinical infection for this virus. So that's sort of that 40% only, or 38% reporting some sort of illness that is consistent with Zika. What do you think about that 19% who report having symptoms despite not having antibodies?
Some other similar infection, not Zika.
Right, so that's definitely one possibility, right? And that's a very strong possibility that, you know, we're asking about symptoms of Zika, which are like aches and some like, you know, bloodshot eyes and some other things that are just not very specific, right? That lots of other diseases could cause this. Anything else?
So maybe RS or AGM is one sense.
Right, so the other thing is we tend to believe assays, but they're not perfect, right? That it might not be sensitive. It might be that a person just didn't develop the antibodies, right? So that, you know, that there's some individual variation in response in terms of creating antibodies. The other thing is that studies are messy, right? So this is a CDC team on Yap Island, and the analyses were, these blood tests were being done in Atlanta, right? So you can think about anything that could go wrong with these sorts of studies might go wrong, right? So like blood samples not getting shipped properly, things getting turned, you know, samples getting mixed up. I mean, the CDC knows what they're doing. You know, I think they tend to be, you know, very rigorous, but it is still like the logistics of this are not easy, and that things could go wrong. And then they also did an incidence surveillance. So what they did was they went to all of the health facilities. Again, this is a small place, so you've got 1 hospital and 4 medical centers. They went through the medical records and got all of the suspected cases. So rash, arthritis or arthralgia, and then conjunctivitis. And then this is confirmed, so that was the suspected case definition, or confirmed was the symptoms plus either antibodies or an RNA test. What they found was 185 suspected Zika disease cases. A large number of them were confirmed, right? So they've got RNA and antibody evidence. 59% were probable, so they didn't have the RNA test was not positive, but there was antibody evidence. 72, no one did the test, and then 5 tested negative, right? So this is sort of a classic incidence study. This is, you know, if you were to join the CDC Epidemic Intelligence Service, this is the sort of thing that you would do. It answers questions about how many and who. It doesn't necessarily answer questions about why. In this case, they actually already knew why, right? So they already knew that they were looking for this particular virus, and they had some tests to do it. So when you start going into questions about why, sort of the most basic study design is an ecological study. So this is the correlation between the rate of disease and the rate or the degree of the exposure, both measured on a population level. So this is a classic one. This is a 7-country study. And what you see here is that you've got CHD deaths. So this is the number of deaths from heart disease per 100. And then you've got on the x-axis percent calories of saturated fat, percent of calories from saturated fat. And you see a correlation coefficient of 0.8 between these two. And so this is 7 countries. Some of the countries have multiple sites. So you've got more than 7 little dots. And you can see that the places where you had the highest percent calories from saturated fat, you have the highest mortality rates. So the one all the way up in the corner is Eastern Finland. And in this study population, there's a very high intake of fatty acid, saturated fat. So the sort of classic thing people would eat for lunch is butter and cheese sandwiches, which I always thought was kind of ridiculous. And I went to Denmark a couple weeks ago and got a butter and cheese sandwich, and it was really quite delicious. So this is not the only evidence that saturated fat causes heart disease, but this was sort of the start of the evidence that saturated fat causes heart disease. So this was done in the 60s. It can be done using existing data. So that data was used was collected from vital statistics, and it was collected from agricultural information about food production, imports, and exports. The problem is that there's an ecological fallacy that people having the events might not actually be those who are exposed. So even within a population, there's variation in how much saturated fat there is. There's also huge confounding, right? So I've not been able to find this, but one of my professors when I was in grad school showed the same graph, but looking at bathtubs per capita, and you see basically the same correlation, right? So in part, the saturated fat is a measure of, wealth, essentially, particularly in the 1960s. Going sort of a step more detailed, we can do a cross-sectional study. So in this case, you've got your outcome and your exposure measured at the same point in time, and you're assessing prevalent disease and prevalent exposure. So this is one of the studies that I did when I first came to UAB. So looking at unrecognized MIs. So we knew that about 1 in 5 MIs are not actually clinically recognized. So we were looking at the association of these different risk factors with unrecognized MI. The intent of this was to sort of see, can we do some sort of screening or some sort of like easy screening and then do follow up with additional screening to see if people had a history of heart attack that they didn't know about. Turns out it doesn't work. But we do see that there's an association. So older adults were more likely to have a history of unrecognized MI, current smokers, all the things that you would think would be associated with heart disease. We did this because it's relatively simple logistically. It's relatively fast. The problem is that the prevalence of the outcomes, so prevalence of having an unrecognized MI is related to how often an unrecognized MI happens and how long you're living with that unrecognized MI. And in some cases, the disease may change the exposure. That's not a problem here, but if we think about how, so this is a regards study, how did people wind up in regards with unrecognized MI? So first they had to have an MI, right? That MI had to cause a Q wave, so that doesn't always happen, so some MIs do not. The MI had to not be recognized, so maybe, and there's a couple ways that could happen. So one is the person thought they had indigestion, never went to the doctor or never had any sort of symptoms. Another is that they went to the doctor and the doctor, or went to the ER or the hospital and they didn't get diagnosed. Or they could go to have symptoms, go to the ER and the hospital, get diagnosed, and then not understand their diagnosis or not report it to us. So all of these things could happen. They had to survive, right? And then they had to, their Q wave had to persist, and then they had to sort of say, yes, I will join the regards study. So all of these things had to have happened in order for them to have seen us. So this is why having that sort of cross-sectional study, it has to, how long are you living with this Q wave that is indicating having had an unrecognized MI really affects what our results look like. For the issue of disease changing exposure. So when I was in grad school, one of my classmates was interested in lupus. And there were all these studies that were coming out saying, hey, people with lupus have lower serum vitamin D than people without lupus, therefore low serum vitamin D causes lupus. What's the problem there? Anyone? Ken?
Sorry, say it again.
So if
Looking
you...
at a patient note on a patient with lupus.
Okay, perfect. So if you found that patients with lupus have lower vitamin D than serum vitamin D than patients without lupus, what's the problem with saying that low vitamin D causes lupus?
And it could be confounded, you don't know what their baseline level was.
Right, so
It could be an epiphenomenon. It's hard to know what the direction of the association is.
It's really hard to know. And then in particular for that question, right, so vitamin D comes from the sun.
Lupus cause low vitamin D, or does low vitamin D cause lupus is the question.
Right.
In a cross-sectional study.
And if you've got, right, so people with lupus are sun sensitive, right? So you tell people with lupus not to go out in the sun. And if a good portion of your vitamin D comes from sun exposure, people just that having lupus means that you're less likely to get vitamin D from the sun, right?
So that's why, for those of you reading the New England Journal, the VITAL study was just published, which is the largest study of vitamin D and no effects of vitamin D on immunologic outcomes for cardiovascular outcomes.
Yes.
Done prospectively, this randomized controlled trial. So that's the way to answer this question, looking at a cross-section.
Right. I mean, it's an interesting observation, but it's not necessarily going to tell you about cause and effect. So then we can also think about cohort studies. So here we identify the population at risk of your disease of interest, and you follow them up to see whether the exposed groups or the groups that are more exposed are more likely to develop the disease or develop the disease more quickly than the unexposed groups. So the example here is looking at alcohol and MI. So what they've done is they had 38,000 men who completed questionnaires about drinking habits in 1986. Every 2 years for 12 years, participants were sent questionnaires. Have you had a heart attack? If the questionnaires aren't returned, then they start looking for deaths, right? Looking for death certificates. And they were looking at rates of heart disease by alcohol drinking and by types of alcohol beverage consumed. Direction. And so here are the results, right? So these are kind of on top of each other, which is kind of a point. So you will often hear in the press that drinking red wine is better for you than drinking other types of alcohol. But in fact, more alcohol for any of these types of alcohol seem to be associated with lower rates of MI. There are some issues here, right? Because the data suggests that more alcohol is better for your heart, up to really actually pretty high alcohol intake. But it starts increasing your risk of cancer and accidents and a lot of other really terrible outcomes, right? So we're not recommending that you drink 50 grams or more per day of ethanol. The other issue is that people who really are drinking heavily generally don't join epi studies, and particularly studies like this. And so, you're preferentially selecting out people who have, really problematic drinking. This group did another really interesting study, and so what they looked at was in places. So in Germany, right? Some parts of Germany drink wine, some parts of Germany drink beer, as it sort of most commonly. And so if you're a beer drinker in the beer drinking parts of Germany, you do better than if you're a wine drinker in the beer drinking parts of Germany, and vice versa. So what that suggests is that it's people who are sort of drinking in a culturally appropriate and moderate way. And if you're drinking in the non-culturally appropriate way, then that is you're probably a more problematic drinker. Anyway, kind of interesting. There was supposed to be a trial that got pulled. So if you're interested in that, you can look at the Washington Post. There are all kinds of articles about that. So with the cohort study, you have the temporal ordering, right? So you know that the drinking preceded the MI. So that helps with sort of deciding, is this cause and effect? You're looking at incident disease, but it takes a long time and a lot of follow-up, right? So the less common the disease, the more people and the longer time required, right? So this is not a quick study, right? You had to wait 12 years. So first, and if you think about the time it took to get the study funded, and then get it up and running, and then get the data, clean the data, right? So you're talking about 18, 20 years that it takes to do a study like that.
But of course, you could do it as a retrospective cohort.
Well, right. So retrospective cohort means that you still have that temporal ordering, but you're collecting the data after something has occurred. So for Muggs' study design, that would be a retrospective cohort, right? Because you're sort of building a cohort out of data that's already been collected. Do you have this kind of granular data on alcohol intake in the clinic notes?
And Incidence? Not to this level of detail, no.
Right. So you could look at, in the clinic notes, which are a little bit about what's in there. There is information about alcohol intake. I think it's the Audit C, right, which is a screening questionnaire for problematic alcohol intake. So you couldn't look at beer, wine, liquor in that same way. And that is much more detailed than what's in sort of general, like primary care clinic notes. Or much more systematic, I guess it was probably the better term there. It's much more systematic. So for certain things, you can do a retrospective cohort. For other things, not so much. For a case control study, you identify, unlike a cohort where you're starting with a population at risk, in a case control study, you identify cases of the disease, and then you identify a control group without the disease, and you compare their exposure history. So, for example, there's a big case control study that's done on adverse birth effects. And so they do a whole bunch of different ones, but this particular study was looking at persistent pulmonary hypertension of the newborn. So this is a condition where essentially the fetal circulation does not properly switch to the non-fetal circulation at birth, right? So there's too much and too high pressure blood going to the lungs. So they have the 377 infant mother pairs where the infant has PPHN, and then 836 infant mother pairs without PPHN. And they interviewed them about exposure to SSRI antidepressants during pregnancy. Right, so this is, you know, the mothers already know what the outcomes are at the time when these were assessed, when the exposure was assessed. And so one of the things you worry about there, right, is that people might report differently depending on whether or not they know that their child has some sort of adverse birth outcome. And in particular, you know, you might have women remembering exposures that, you know, differentially based on whether or not, based on what happened to their infant. So this study is actually really well done. They train their reviewers really carefully to not in any way have leading questions. They also ask a lot of questions, so they kind of embed questions they're really interested in and a bunch of other questions that they're not as interested in order to sort of take away the, hey, you know, like, because if you walk up to someone and say, did you use SSRIs when you were pregnant, that's a very different thing than saying, okay, we're going to ask you about all these different medications, all these different things. The other thing that they did was they looked at when you used SSRIs. So what they found was that after week 20 of gestation, there's a much higher risk than before week 20 of gestation. And this is important because if you think about the biology of PPHN, it's really something that happens at the end of pregnancy and the beginning, you know, at the time of birth. And so this suggests that maybe it actually is because you don't see anything early in pregnancy, any association early in pregnancy. I will say that there have been a bunch of other studies that, and some have replicated this and some find nothing. Anyway, that's a case control study. So these are efficient when outcomes are rare. Right, so this is luckily not something that happens very commonly. So case control studies are often used for rare disease, but a lot of times your exposure is measured after your outcome. And your outcome may change your exposure and may change the report of exposure. So that is problematic. You'll also get case control studies that are nested within cohorts where, you know, you'll take blood samples, say on all 38,000 men, and then just select the cases in some sample. And there you don't have the issue of the exposure changing. That's really just a matter of saving money to, you know, inefficiency, and saving blood samples. Because the blood samples in a study like that are highly valuable and prized, right? So you want to use as little as possible. And then you don't have as much issue around the exposure measure, and then the exposure is not measured after that outcome.
You have a minute about case control studies. Can you talk about matching cases and controls? I think one thing that comes up oftentimes is being careful in matching and being careful. If you go with hypothesis, you obviously can't match on the exposure of interest.
Right. So, okay, so oftentimes case control studies will be matched, and they'll be matched on some set of characteristics. Once you match, you can no longer look at that characteristic as a risk factor. So you absolutely do not want to match on anything you think is a risk factor that you are interested in examining. because now you have artificially made it so, say if you match on age, that your cases and your controls are exactly the same age, right? Often we will match on age because we often already know the relationship of age with these diseases, right? It's something that we usually go into a study already having an idea about. But, you know, if you match, you know, say you matched on age and race, you can no longer look at racial disparities in your study, right? Because you have now just set your cases and controls to have the same distribution. So you want to be careful about it. What you want to match on is strong confounders that you don't care about, right? That you already know about and you're not interested in studying. And what that does is it makes it a little bit more, your model's more efficient.
Give an example for the outcome, which is the exposure.
So what kind of outcome could change your exposure? So you know, the example I gave, your outcome could change your report of your exposure, right? So it could change how you remember your exposure, and then you're telling us. And then you could also have something like, if you were, say, doing a case control study in MI, right? And you're then looking at inflammation, right? So you took your MI cases, you looked at inflammation, you took your non-cases, you looked at inflammation. Having that heart attack is going to increase your inflammatory response transiently, right? So that the disease itself is increasing the exposure that you're looking at. Or, you know, you could look at, say, kidney markers, and, you know, having an MI and being hospitalized and all those treatments can actually cause acute kidney injury. Other questions? So there are tons of epi textbooks out there. Two that I like are this one, Epidemiology and Introduction. It's pretty easy to read, but it's theoretically very rigorous. The other one, Principles of Epidemiology and Public Health Practice, is particularly nice because it's free online. So if you Google this, it'll pop up. It's published by the CDC. We teach a ton of classes on epidemiology in the School of Public Health. We have a whole department of epidemiology. So, you know, if this is something you want to do, and I know that some of you are epi students, so you already are taking these classes. This is one of the papers, and this isn't, again, the only paper, but this is a nice paper that talks about the Finer and PICOT criteria. When you start thinking about reporting on epidemiology, the stroke guideline is really helpful. So there's a sort of checklist. This is similar if you are familiar with the Consort guideline for clinical trials. This is the sort of parallel guideline for observational research, and specifically epidemiology. And it's got a checklist, which is just kind of like, did you include this thing or not? But then it's got a really nice explanation. And if you really want to go down a rabbit hole, there's like, when this was initially published, there was accompanying like 20 different editorials. So you can see everybody's ideas on how this works and whether this is useful or not. It's also useful when you start thinking about evaluating a study. Did they include all of these things? There are a number of different epidemiology or cores around campus that offer support for observational research, one of them being the CCTS, Biostats Epidemiology Research Design. So I'm part of that. We have drop-in clinics, seminars, and webinars, and then one-on-one consultation. There are others, so for example, the Center for AIDS Research has one, the Nutrition Obesity Research Center has one, and the Cancer Center has one. There's a lot of overlap, so I'm in the CCTS one and the HIV one, so. Thinking about this is most useful in the earlier the better, right? So if you come to me and say, hey, I have this data, what's my study design? I can maybe help you, but it's much better to think about, like, you think about this earlier rather than later. Everyone's a lot happier when you think about it before you actually collect your data. And I am happy to meet. So part of the reason why I'm in multiple cohorts for this is because I think it's really interesting and fun to sort of sit down and talk to people about study design and how to answer the questions that they're interested in. So you're welcome to contact me. Thank you very much. Any final questions? Okay, great.